Okay, so today we're going to go over pediatric musculoskeletal, primarily from a developmental standpoint with some other idiosyncratic things stuck in at the end. We've got a little bit of rheumatology and a little bit of infectious disease, which you'll probably get from other instructors as well. However, it's nice to have it with the pediatric overlap, and it kind of reinforces some stuff. So let's go ahead and screen share here. Old school PowerPoint, an OG PowerPoint here for you. Okay, so moving on, outline. So we'll go over some skeletal maturation stuff. Primarily what separates pediatrics from the rest of the population is as they're developing. A little bit about history and definitely some physical exam stuff. Then we'll go over some injury type things with some cases kind of smattered in there, as well as some review stuff. So the developing skeleton, basically they're going from this cartilaginous structure to more dense bone tissue. So there is a lower mineral content in respect to calcium and phosphorus, so they're slightly less brittle. And this leads to a lot of the green stick torus fractures in the ability of the pediatric skeleton to quickly heal, although it does affect in some ways cause increased chance to have an infection due to the vascularity of the bone. So it does increase the likelihood of infection due to the hypervascularity of the bony structures. So as we age, the bone's going to remodel, and it starts as this cartilaginous tissue, and then as remodeling occurs, more bone is reabsorbed in the form of calcium and phosphorus, and that allows the appendicular skeleton to grow in length. The bone is usually reabsorbed in the physis, but these are also areas of vulnerability to infection and near the epiphysis and physis, as well as infarction. And there is definitely hyperelasticity to ligamentous tissue as it is starting to become more calcified and dense. So obviously changing what's normal is going to be different for all individuals. However, there are a lot of themes that go throughout. So these are just some x-rays from newborn, and you can see the lack of hard bony tissue and a lot of area that you don't see anything in there. Well, that's just the calcified portion, or the portion of the cartilaginous tissue between bones. The portions that you can see of the bone is the calcium and phosphorus that's laid down. So obviously, as we age, we start to have a better look, but it's really difficult to assess these x-rays in these little guys, because it's difficult to know, is that a forming bone or a fracture? And so just as time goes on, the more pediatrics that you look at, the better you'll get. But that's also why we compare side to side a lot of times with pediatrics, because of the difficulty to assess the skeletal structure and know what's supposed to be there and what's not. History. So we want to get a good birth history. What position were they in during birth? Were they a breech birth, or were they head first? Any exposures, any inheritance problems? Make sure that their developmental milestones are being met. Any injuries, and then any disorders that may be at that age based on the typical age of onset. Physical exam. So we're going to always, age is always going to determine how the exam is performed and what things we're actually looking for. We're going to look for signs of systemic disease, presence of some congenital syndromes based on morphology, and then a general musculoskeletal exam, and then a more detailed specific exam as needed. There is a YouTube video link here on just assessing the pediatric gait and just kind of a general presentation, which is helpful. So this kiddo here, what in this child with osteogenesis imperfecta type 1, what kind of HEENT abnormalities can you see? So the case reads, a 3-year-old with tibial fractures after a minor fall has a long-standing complaint of back pain and bruises easily, otherwise has a normal past medical history. So what this child is suffering from is this osteogenesis imperfecta, and the HENT abnormalities that you can see is actually some bluing of the sclera of the eyes. He's got this kind of keratotic irritation around the mouth as well, like a cheilitis, and then he also has some widening of the nasal bridge. And so those are all morphologic traits that have to do with osteogenesis imperfecta. Musculoskeletal exam, so it doesn't change with kids. We're going to inspect, palpate, and do some range of motion. Clinodactyly is this malformed pinky, and then polydactyly is the extra digit there that you can just barely see on the lateral portion of that hand. And then they're just taking this baby through kind of a general exam. Non-traumatic disorders, we want to look for those. We're going to look at the head, neck, hips, lower extremities, and spine. Cranial stenosis versus plagiocephaly. So just very broad words. Plagiocephaly is less documented here, but you can see the plagiocephaly is a malformation of the skull, and we've got these different suture lines, and if those suture lines should close prematurely, then you can get a plagiocephaly. So that's just a plagiocephaly just indicates that there's a deformation of the skull. And a craniostenosis is actually that the cranium is squishing together. So you can see here this stenotic portion. The cranium just basically is a loose word to say that the cranium is also malformed. So the difference here, and I'll go to the next one here. So what I want you to do is go ahead and watch this as well. What is normal? The process of overgrowing of the large and small fontanelles in infants. This is a very helpful YouTube video that helps you kind of get your mind around this. But this is the normal kind of closure of these suture lines. This is a scaphocephaly. So in the sagittal plane, that suture has closed early, causing elongation of the skull. Here we have a normal developing child. And then this plagiocephaly means that the head is somehow abnormally formed. It can be just a normal formation from position, but it can also be an abnormal suture line closure. And those are really the things that we need to focus on here. A lot of these forms will have a name with them. So the brachiocephaly is just the formation where the posterior portion of the skull is a little bit heavier and more broad, as the front is more narrowed. If that's a little bit more pronounced, then you have this trigonocephaly, which is just like a triangular formed skull. So here you've got the suture lines. You should be at least loosely aware with the basic suture lines, right? So we have the coronal sutures, the lambdoid sutures, and the posterior fontanelle. The anterior fontanelle is this portion right in front that we kind of palpate to assess for the child's hydration status. Unilateral occipital flattening. We need to assess this to find out if we really have a premature stenotic portion or if we just have a positional molding abnormality. So a stenosis is going to indicate that the suture line had closed abnormally early, whereas a positional molding is usually either due to musculature, comfort level, or some other positional abnormality that's causing the skull to malform. At any rate, we need to assess this because what we will find is that with positional molding, we're not as concerned. They can be placed in a helmet or monitored, or we can lay them on their other side. But with these lambdoid or any early suture closing, we need to have them evaluated by a maxillofacial pediatric orthopedist to see if they want to do surgery or not. So a big thing that separates the two is that the ear is displaced posteriorly on the affected side if it's more pathologic. So remember, posterior pathologic. So if the ear is more posterior on the affected side, then that's pathologic. That's a stenosis, and that needs to be evaluated and referred. If it's positional molding, then the ear will displace anteriorly. So those are two things that you can really. So craniostenosis versus plagiocephaly. So you get really hung up on these terms. They're not going to use these terms all that often. I don't know if it's really high yield, but the natural history is that a craniostenosis gets worse and can cause permanent abnormalities, and the treatment for craniostenosis is surgery. So if we identify an early closure of a suture line, then we need to refer to orthopedics. Torticollis. So a torticollis is just a pulled neck muscle or an abnormal orientation of the head secondary to a super tight muscle. And in this case, it's this sternocleidomastoid. So this muscle gets super tight, causes the child to kind of cock their head. This can be due to a tight muscle or can also be due to some sort of congenital abnormality or a fibrosis of this tissue. So sometimes the cause is a vertebral abnormality, although it's generally caused by this fibromatosis of the sternocleidomastoid. Basically, you just want to be aware that this is out there. We would definitely refer. If there is a concurrent plagiocephaly, then we could potentially use the helmet, right? The plagiocephaly is the malformation without abnormal suture line closure. And so that can be corrected with helmet. Hip dysplasia, so we want to inspect hips. We want to do the ortolani and the Barlow. There's a few different things that can predispose people, like a breached delivery can predispose a child to developmental hip dysplasia. This is one of the things, or one of the reasons why we want to take a really good history, birth history on these kiddos. There is this test that you can do where you look at the creases of their buttocks. So you're, checking out the baby, and you're going to assess, obviously, this posterior spine. We always do, so that's part of it. And then you look at these folds, to see if the folds are lined up. So that's one thing that you can use to kind of help. However, 25% of infants will not have normal leg creases, and so make sure that you're good at the ortolani and Barlow to make sure that doesn't exist. So this is a YouTube video that talks about the ortolani and Barlow. Barlow is the bad guy. Always remember that, because he dislocates the hip, and ortolani is the nice guy. He puts it back in. So basically what you're doing is the Barlow test. You internally rotate the femur, and then you apply a posterior pressure, which would push that dysplastic hip right out of the socket. Whereas with the ortolani, you're actually putting it back in. So you're abducting the hip, or externally rotating the hip, and and putting an anterior pressure, and that's causing the hip to relocate. So Barlow's the bad guy, he puts the hip out. Ortolani's the nice guy, puts it back in. The Galeazzi sign is just where you have the child laying flat, and what you see is some sort of leg length discrepancy. And what it is that you're actually seeing this femur here that's slipped up. So it should be sitting here, right? And it would extend right there, but it's not. So it's sitting back, and that's what's causing this leg length discrepancy. So that's called the Galeazzi sign. You guys, these things are so crazy testable. That's the problem. So you got to make sure that you know them all, because I remember Galeazzi sign being on my pants. So just keep it in mind. Sometimes these seem cumbersome, but they are really testable. Okay, so degenerative joint, spontaneous dislocation of the hip due to lax ligaments. So this ligamentous structure that's really fibrous in the tissue socket, in the hip socket, doesn't work all that well, or is just extra loose, and so they can sublux, right, which is just living on the edge of the joint, or they can completely dislocate. There's then graded from a low to a high dislocation. So the difficulty here is that plain films are not going to reveal this early on, right? So we do the Ortolani and Barlow, we think it's abnormal, we've got a positive Galeazzi sign, and now we're going to take some images, we're going to do an x-ray. Well, the problem is that the femoral head has not calcified yet. So the x-rays really are not of high yield. We really need an ultrasound. Right about a month, if we're suspecting this, we need to do an ultrasound. The ultrasound will show that cartilaginous structure of the head and whether it's in the acetabulum or not. And so anyway, that's something to take note of. At about 6 months, 4 to 6 months, we can start to think about x-rays. So what do we do to treat these kids? Well, the earlier the better always with kids. We want to treat them as soon as possible, but this harness thing that just looks like this kind of crazy contraption is utilized to get the hip in the socket so that the socket and the ligaments will tighten and the socket will sit nice. They can cast them, or they can do an open reduction in surgery. When it's missed and they're older, there are some other signs. This Trendelenburg sign we talked about earlier in some earlier lectures. Basically, it's that the affected side is too weak to hold the pelvis. So on the hip that's dislocated, right, when they stand on that leg, they're going to get weak, right? So in this girl here, she stands on the unaffected side and she's strong enough, right? She can hold this. So this hip's in the socket. But when she stands on this hip, this hip's already like way up here, right? So it can't hold that weight. And she starts to let the contralateral hip go down. And that's a problem, right? So that's a positive Trendelenburg sign, and we need to definitely image this girl, right? She's 4 years old, so we could easily do that. And then here's that positive, what sign? Galeazzi sign. So, okay. Beyond infancy, we may see an antalgic gait. We can see decreased range of motion. This picture here is showing that this child, as he tries to abduct both of his hips, see how far he goes there, and then that one doesn't go, and that's probably because he's out. Same thing here, very poor range of motion. This would be the this is in a shortened position. This must not be the same kid, because see, this is the hip that can externally rotate, and this hip has virtually none. So anyway, interesting. So why do we care? Well, we care because there's blood supply there. And how also we need to know that there's a nerve that sits here, and the nerve distributes down the medial portion of the groin and into the medial knee. So a lot of times these kids come in with medial knee pain. They don't have any hip pain. So just something to know. Leg calf Perthes. So this is another condition that we'll see. This is considered an avascular necrosis of the femoral head. So probably some sort of trauma or abnormal development, but at whatever rate, this portion doesn't get perfused with blood. And so that's resulting in this leg calf Perthes. It's much greater in boys, and age 4 to 8, they're going to come in with a limp. Unexplained limp with no trauma, right? So these kids will just come in, oh my gosh, all of a sudden this kid's so limping and we don't know why, and he doesn't really hurt, he didn't fall, and then you do this x-ray and bam, you see this femoral head that just looks terrible. It's not perfused, it's not calcified, particularly when you compare it to this side, right? So you want to do comparison films so that you can see it. Now, this is after non-surgical treatment, so you can see that the head is looking a lot better. This kid's probably always going to have a hip problem, but at least we've got it. There's some other treatment for it. So you can do non-weight-bearing treatment, these serial casts, which just look terrible. But look at this, 2 to 5 years to resolve. So that just sounds terrible. There's also a surgical osteotomy that can be performed where they take out some of this and it's just a crazy deal. But anyway, that's the leg calf Perthes disease. And then we've got the SCFE, which is the slipped capital femoral epiphysis, which sounds really, really annoyingly complicated, but it really isn't. You've got this cap, right? So there's the growth plate in the femoral head, right? There's the femur, there's the greater trochanter, all that, right? There's the lesser. Okay, so this part, for whatever reason, this probably necroses or does not have good flow, and this starts to slip down. So it's like a fracture that never happened really, but it behaves like a fracture. So you'll get this overweight, usually, unfortunately, you've got this overweight 12 to 15-year-old male or female with a limp, and could be chronic or it could have just happened. They're going to have decreased internal rotation and abduction. So they can't move their leg away from their midline, and they can't rotate it in. Okay, so those are the things, and it's because of this. So we want to immediately stop weight bearing and take an x-ray, and what we'll see is this, and we can grade it, right? It's just super confusing picture here. So grade this earliest grade, a mild SCFE, is where you just see how these don't line up. Okay, and then as it gets more moderate, it starts to torque, and this space is getting bigger, and then it's huge. Now what they're doing here is they're actually looking up on it with the x-ray. So their x-ray machine's up here and they're looking down at it, or they're looking at the frog leg, and now you can see how it still slips off. So the treatment here is we need to surgically pin this sucker. Okay, so look at that. So there's a normal capital epiphysis, right? The cap, and then the growth plate, and then there's the slippy. So you can see that if you look at the neck of the femur, it's not going to line up. And look at the neck of the femur there. So if you see an x-ray on that, you should be able to pick that up. May interpret blood supply, right? If this falls away enough and rips all these arteries, then this whole thing can necrose, and that's why we care. So what would happen is this really highly vascularized area would start to slip off, and as it slipped off, these vessels would rupture, and then eventually this loses flow and dies, and that's not a good thing. Right? Okay, continuing on the lower extremities. So you've got all these foot disorders, right? You need to know these for whatever reason, but it's genu Varus. So if they are like those old cowboys, they're going to be varus, and if their legs kind of go out and make an L shape, they're going to be a valgus. Okay, so very much horse riding, right? Varus. This syndactyly is just webbed toes. See how these toes are webbed? Talpes equinovarus. Wow, that's why they call it clubfoot. So we'll talk about that a little bit. This is that physiologic bowing. There's actually a normal amount. So as a newborn, they're riding the horse. Then at 2, they're normal. At 2 to 6, they're pretty normal too. And then from 4 to 6, they're basically straight up and down. So what they're saying here is that then you can move to this valgus, right? So they basically start in the varus and move to the valgus. So here's the leg bowing that's not normal, right? So we know that some is normal, but obviously this is not normal. Okay, this is called Blout disease. Blout disease can be associated with some neurologic abnormalities. So if we identify this, we want to have the child probably worked up by a children's type hospital or someone who specializes in these type of syndromes. But this Blout disease to us for MSK means that there is a inhibited growth of the medial aspect of the proximal tibia. So dissect that for a minute. So inhibited growth for the medial aspect of the proximal tibia. So what happens is the tibia is growing in length, right? And this portion's growing just fine, right? But this portion's not. And so that's why you have this physiologic bowing as this angle. The tibia looks like this, right? So it's like if you're stacking blocks, this block is going to look like that. And that's causing them obviously to deviate into this varus positioning, okay? So Blout disease can be fixed with surgery, particularly if we catch it early. If bracing fails and it's persistent, then they'll do surgery on these kids and pretty good outcomes. Torsional deformities, so in towing, you can have a femoral anteversion where the femur toes in. You can have a tibial torsion where the tibia goes in, and then you can have marked metatarsus, so your metatarsals are adducting. Metatarsus adductus. So lots of this sounds just super, super complicated until you dissect it. So torsional deformities, we need to assess for a physiological cause to the in-towing. So we'll check hip range of motion. That's a good thing to check. And this is just showing that when you're on your belly, it's really weird because look how the external rotation is actually looks like you're rotating in, and internal is external. But you can see what he's doing is he's twisting at the foot, and this is the other leg there on the upper picture. So femoral anteversion is when the femur kind of rotates in. It's this in-towing from 3 to 10 years old. The kneecaps face in. Girls greater than boys, 99% will resolve spontaneously. And you'll see them sitting in this W position just because it's more comfortable, because that's the way that their femur actually twists. Rarely there's a problem. So usually it's just a goofy way these kids sit. Interior tibial torsion. So this is the most common in towing. It's also usually seen bilaterally, and 99% resolve spontaneously. We can put them in special shoes. Braces don't really speed up the progress, so it's not of high yield. It's probably not covered, and it's probably not necessary. Metatarsus adductus. So metatarsus adductus is basically a flexible convex lateral surface of the foot. So the surface of the foot makes this kind of in-towing convex shape. And if it's nice and flexible, see, we can flex the foot into a normal position, then it's probably going to resolve. If it doesn't, or it's more stiff, we want to think about referring. The reason why we would refer is that we'd be concerned about a possible clubbed foot. This would be a rigid inverted foot. So the difference is really rigid or flexible. And that's due to a tendinopathy. Some of them are going to resolve, but we definitely want to get these kiddos to a orthopedic pediatrician. Club footing is usually serial casted. Ponseti is the dude that made this up. You can also use braces, but it's just this slow progression toward normal, usually about 15 degrees per casting. Flat foot. So what is normal? Well, there's this variation of normal, but if we see this kind of tiptoe walking, that's a sign of flat foot, mostly physiologic. It usually physiologic, normal, less than 6 years, and then as they get older, it becomes a little bit more concerning. We may want to think about some orthotics to correct this posture of the foot, right? So you can imagine that if this posture is happening while we're bearing weight, then the knees are kind of taking the brunt, and the hips are taking the brunt, the lower back, and so on and so forth. So they may have pain in the knee actually rather than the foot and ankle. So we can put them in some orthotics, we can refer them, we can teach them some calf stretches. We want to make sure that it's not rigid. If it's rigid, then we definitely want to refer. The spine. So moving on from the feet to the spine. Most of this you guys may have gone over. This is just a radiograph, MRI that shows a spina bifida. And then these range from being just these terrible spina bifidas to just non-concerning, non-problematic. But anyway, that's one thing that we can see in the spine. We'll also want to look at the curvature. At the neck, there's a normal lordosis. And then in the thoracic spine, it's considered a kyphosis. And in the lumbar spine, a lordosis again, and that's normal. We do assess for symmetry for things like scoliosis. So we want to see how those shoulder blades look. We assess the height of the bilateral shoulders, then go down to the blades, and then you can see this asymmetry in the musculature of the thoracic spine and lower back, mostly in the paraspinal region there. You can also see that the left hip is a little bit more prominent on this little girl. So just some of those things that we want to look for, then we can refer. Just remember that with kids, everything that gets picked up earlier is better, right? The earlier, the better, because they have a better outcome. So this is a scoliometer. We can use this to assess for scoliosis. Idiopathic scoliosis is the most common. It's primarily in girls. There's usually no pain with this. There may be other causes like vertebral malformation or tumor, also neurovascular disease or spinal cord diseases. So idiopathic scoliosis, is less than 6 degrees by scoliometer. Can be monitored by primary care about every 6 to 12 months. If it's greater than 60 degrees, we should send them for some special x-rays, and we should ask that the radiologist measure a Cob angle, which sometimes they will, but usually you have to ask it. You need to get an A and P in lateral view and ask for the Cob angle. You can refer if it's painful, if there's a left-sided curvature to it, if it's greater than 15 degrees, if the onset was earlier than 11 years old, or if the patient has any other medical problems. Those are the kind of red flags there. So usually if they're less than 50 degrees, we try to put them in a brace or do something else conservative. If they're greater than 50 degrees, as far as the Cob angle is concerned, then we need to send them to an orthopedic surgeon. So this is how they calculate the Cob angle. I am by no means going to try to teach you that, but basically what you need to realize about the Cob angle is that we take the vertebra that's off the most at the bottom and off the most at the top, and then that's where you make this line for the Cob angle. So go ahead and watch this YouTube video on it. The Cob Angle is actually decently high yield for both exams and for the PANCE. So I'm not going to try to explain the Cob Angle because it's a little bit esoteric. However, you do need to know where the Cob Angle starts, both proximally and distally. So figure that out. Kyphosis can be from postural, which is a flexible kyphosis, and then a congenital kyphosis could be progressive. There's something called Sherman disease, which is seen in early teens, usually with rapid growth, similarly in boys and girls, and there's often pain. But there's going to be greater than 3 adjacent wedge-shaped vertebrae, and you can see they've kind of zoomed in on this, but there's 1, 2, 3, and these are not normal vertebrae. See how they're angled? I'm making it extreme, but they're angled, and so that's what's causing this to kind of bow like that. So usually this is in the thoracic region, but it's similar to scoliosis. However, it's in the frontal, it would be in the frontal plane. So you have this frontal plane scoliosis. Kyphosis epidemic. So yeah, we're using our phones a lot and our computers a lot, and now we're even using them more. And that's just causing us to look deformed from this chronic forward head posture. The head weighs 9 pounds normally, and in normal posture, that feels like about 12 when you add the lordosis. And if you just go a couple inches forward, your head becomes really heavy and leads to further kyphosis. So just to review, these are things that you guys need to be able to answer. So what is the best diagnostic test for DDH? Location of pain from diseased hips. This is a radiation. Hip disease in a limping 6-year-old boy. Hip emergency in a 10 to 15-year-old obese child. Characteristics of a 3-year-old with Blout disease. Facial characteristics, please. Rotation at what level lead to in-toeing? 4 components of clubfoot. Is idiopathic scoliosis painful? So now let's get to injuries. First of all, what type of injury is this down at the bottom? It's a Colles fracture. Also, we're going to talk about nursemaids, elbows, sports injuries, and overuse injuries. So fractures compared to adults, fractures are more common in kids. Kids are very active. They also have this weak link at the growth plate area. Developing bone is more flexible, but their healing time is more rapid. And they have a less likelihood for non-union. Most of them aren't smokers. And remodeling is greater. Treatment usually is close reduction and casting. So let's think about this. Here's a infant that sustained a humerus fracture during birth. Look at this, day 1 to 6 months, and that humerus is completely fixed, which is really amazing. Evaluating fractures, well, we want good history. We need to know the mechanism of the injury, what they hit, what they were hit with. Was it acute? Is this a chronic condition? And then where it is in relationship to growth plates. And then obviously always a good neuromuscular exam at the end of the exam. So capillary refill, sensation, range of motion. Evaluating for fractures, there needs to be a really low threshold for imaging. If in doubt, you should always cast or splint these kids and then re-image in 7 to 14 days or 10 to 14 days. Occult fractures are really common in kids. So what does that mean? Well, it just means a hidden fracture, right? A fracture that you don't see because it's really not going to show up. It's not that you missed it. It wasn't there. And then a week later, you re-image them and you see this little line of calcification, and it's like, oh yeah, they were broken. So when in doubt, treat them like they're broken. You'll never lose sleep at night if you do that. General considerations is we want to stabilize any unstable fracture, of course. We want to think about where the fracture is in regards to stability. And then we want to give them some pain control or teach them how to do it with OTCs. And then we need to think about the proximity to the growth plate. Here's some different fractures that you're going to see and names. Examples of complete fractures include a butterfly fracture, a green stick fracture, which is actually considered a complete fracture, simple fracture, comminuted fracture, and a spiral fracture. Example of forces that can cause these fractures could be a tension, compression, a twisting, a bending, or a shearing force. So here's these different fractures. This is a transverse fracture where it goes all the way across. A linear fracture goes with the length of the bone. An oblique fracture goes in a diagonal. An oblique displaced fracture just means that is an oblique fracture and the two fragments of bone are not touching. Spiral fracture is obviously like it says, a green stick is on one side, and a comminuted fracture is more than two pieces. Fracture type, so you can have a complete fracture, which means it goes through both sides of the bone. The fracture line can then be transverse, oblique, comminuted, or spiral. A bucca or torus fracture is in the metaphysis. So we want to look at here. This is the metaphysis or metaphysis. This is where that green stick or torus fracture, and what they'll look like is this little kind of buckle or maybe a ripple. Okay. Growth plate fractures, which we'll talk about. You guys need to commit this to memory. So Salter Harris are these physial, means they're in the growth plate. There's the Salter, which is straight across or separation of the growth plate, then above the growth plate as far as the physis, and this is the epiphysis. Then lower than the growth plate, which is below, through the growth plate, which is top and bottom, and then a crusher, where these two growth plates become amalgamated. All right, so complete fractures. Well, we want to make sure that we adequately visualize the alignment. So we may do multiple views. We may compare side to side. We want to check the joint above and below. Most reductions are done closed. So if it needs to be reduced or fits the criteria for reducing, then it should be done at the time that we see them. Immobilization, which is going to be different for different injuries. Radial head fractures are going to be immobilized for 3 weeks, as where a forearm fracture like a Montegio fracture would be casted for 6 to 10 weeks. Newborn clavicle fractures are fairly common. Sometimes they have to or accidentally do fracture the clavicle. So here's these little fractured clavicles. Oh, poor thing. At birth, but these actually really do well. You may feel some crepitus here, and they could result in a brachial plexus injury. So that's one thing we really want to assess by doing a good neurovascular exam on these kiddos, make sure they're moving their arms okay. Other complete fractures, here's a spiral fracture. This is on a toddler. You can get these toddlers fractures because they're bumbling around and falling and doing dorky stuff all the time. And they're basically just a spiral fracture of the tibia. They can be irritable. They may not want to bear weight. You're going to have to put them in a long leg cast. If it's a femur fracture, so toddler fracture in the tibia, acceptable. Toddler fracture in the femur, probably not from a simple fall. I mean, this better have a good story or we're considering some abuse here. Torus fractures and green stick fractures. So these are in this metaphyseal plate, right? So the transition zone from the physis to the metaphysis, but here's that little buckle fracture or a torus fracture. There's a green stick fracture. There's another green stick fracture. Growth plate fractures. So here's those Salter Harris. Obviously, you've seen these about 3 times. You should definitely commit these to memory. Management, so 1 and 2, not a big deal, but once we get up into the 3, 4, and 5, we want to have them assessed by orthopedics. I had a Salter Harris 2 the other day. I still splinted him and sent him to orthopedics. Basically, I want orthopedics to cast him. I don't do casting all that often, and I want to just make sure he's in the correct position. No closed reduction need to be done, but it looks like a Salter Harris 2, so could be also managed by primary care if you do not have access to ortho easily. So here's some more suspicious type fractures. So these corner fractures, these bucket handles, this is a little bit like, that's a higher mechanism. Also posterior rib fractures, skull fractures in the parietal region, scapular fractures, very high impact, or a sternal fracture. So in that case, we would probably do a skeletal survey, which looks, it's like one big radiograph of the child to look for pathologic fractures, and most radiologists will always know what that means. But here's some fractures, and when we're concerned about pathologic fractures or fractures from abuse, what we're going to see is multiple healing. So different healing times, meaning they didn't just have one trauma, they've had these multiple traumas. Nursemaid's elbow, so a sudden jerk in less than a 3-year-old, it causes dislocation of the annular ligament on the radial head. Basically what you do is find the radial head. You can either hyperpronate as you extend, or you can flex and hypersupinate, which is my best technique, but make sure that you put your thumb right on that radial head and you'll feel it go. And it's back in and you feel like a genius because you just fix somebody with your hands, which is super cool. So nursemaid's elbow, I would definitely highly suggest that you watch this video. It shows the reduction, which next year, if you get to do one, you'll just be super, super stoked. So sports injuries. Oh yeah, on the nursemaids, take an x-ray. X-ray will look normal and then reduce it. You don't want to accidentally have an elbow fracture and you're sitting there trying to twerk on it. Sports injuries, so acute fractures, tendinopathies, or ligament injuries, chronic repetitive stress injuries. So characteristics, if you're talking an acute injury, it's a macro trauma, right? So big injury, and then these overuse injuries are these micro traumas. So take a look at that. Brachial plexus injuries are usually called a stinger or a burner. They're consistent with people that are striking their head against other individuals, like rugby, wrestling, or football. Basically, it's this traction of the neck or a direct blow to the brachial plexus, and it causes neurologic symptoms down the arm, and can cause anything from a palsy to pain. So here's the brachial plexus. I mean, there's a lot of stuff that goes through there, right? You've got the radial nerve, the median nerve, and the ulnar nerve, and they're all coming through that region. So also something we want to consider with these clavicle fractures that are more distal from the midline, or a lateral clavicle fracture. So a brachial plexus injury, these can also occur in bedridden individuals, like in ICU, that can't do anything, and if they get pressure on that brachial plexus, it can cause atrophy. Had a buddy who was hospitalized for months, ended up recovering, but suffered a brachial plexus injury and could barely move his arm. But now he's doing great. We rehabbed him. So anyway, radiographs, MRI of the cervical spine, right? Because we want to look at where those nerves are coming out of the spine, and then they can return once they're asymptomatic and have full range of motion. Chronic use and overuse injuries and growing bone, right? We want to really kind of reduce these. We don't want our kiddos to overuse. However, there's a lot of youth sports now, so it's kind of this dichotomy that we have to live in. So, throwing, running, gymnastics, jumping, anything that's going to put stress on the skeleton can result in some of these injuries. Growth plates, so an Epiphysis is a bony protuberance where muscles or tendons attach, right? So it's this bony portion where the tendon and muscles are constantly pulling, making this recalcify and be bigger. So this would be the lesser trochanter, right? So there's muscles that pull on it, and then the greater, right? And those are the epiphysis is this bump that they, epiphysis, whatever. So apophysis, apophysis, and then epiphysis. So totally different, even though I just said that. So the epiphysis is here. This is the tip of the bone, right? The epiphysis is here, okay? So proximal epiphysis closer to the midline or cephalic epiphysis, and then you have your distal epiphysis there. Let's look at the shoulder joint. So some of these shoulder joints can be repeatedly damaged by throwing at a high velocity. So what happens is this growth plate here, from just being torqued and torqued and torqued, is starting to widen. And this is called literally shoulder. This is why we restrict how many pitches kids can throw, because we don't want them to have permanent abnormality. The growth plate may separate from the epiphysis. So you can have epiphysiolysis. Oh my God, right? Anyway, the growth plate can spread, right? So what was that? What Salter Harris is that? Spreader, right? Not crusher. So it should be one. All right, overuse injuries of the elbow. We need to know that there's 6 ossification centers of the elbow. If you need to go into emergency medicine, you will hate that this occurs. Anyway, so you've got all these different growth plates and they close at different times. And when we're assessing an x-ray, that's why we do bilateral, because if you don't, you will have a hard time investigating those x-rays. Here is a mnemonic that you should commit to memory, particularly if you're going to work in emergency medicine. So the capitellum radium, the medial epicondyle, trochlear, olecranon, and the lateral epicondyle all calcify at different times. So there's this crito, C-R-I-T-O-E, which is a mnemonic that tells you when they're all odd, 1, 3, 5, 7, 9, 11 for when these ossify. Ossify. We like that. Critol. All right. Overuse injuries, right? Anytime you have a bunch of growth plates, you have a more of a chance of having a problem with vascularity. Osgood-Schlatter disease is caused by the traction of the patella tendon on this tibial tuberosity, and it causes intense pain with jumping, running, kneeling, basically playing sports. It can get big and big and big and inflamed. And so what's happening is they're jumping, and they're putting pressure on this all the time, and it pulls, and it just gets reactive here from all that pulling. So, you know, the management is really just kind of conservative. Usually don't need films, but if you do, you should do bilateral. And then just this rice therapy, maybe braces help too. Osteochondritis Desicans. So this is basically just degradation of the cartilaginous structure, particularly in juveniles. And so what you'll see is this medial femoral condyle is affected and they get pain. It's worse with climbing. There might be a joint line tenderness and they may need surgery to debride that. Foot. So Seaver disease is this calcaneal pain. It can cause a limp. it's basically just inflammation of this growth plate. And as the growth plate closes, this discomfort goes away. So it's really just knowing that this exists, imaging, make sure there's nothing going on, give them some, recommendations as far as things to do at home and reassurance, and that when the growth plate closes, the discomfort will resolve. So let's quickly go through spine, and I think that Dr. DeMeo covered a lot of this, so we won't belabor a lot, but a spondylolysis is a rupture or a fracture, rather, of the pars. So the portion of the vertebra here gets fractured. And if you take this special view, you can see this kind of Scotty dog appearance. Very testable, but you need an oblique to see that. So this pars intraticularis, so just this fancy word for this surface that connects the pars to the vertebra itself, breaks. And then what can happen is then this portion here kind of anchors this posterior portion of the spine, and so the spine will come forward like that and go backward like that. So it sounds super fancy, but it's not very fancy. So what do we got to do? Well, we want to strict activity, we want to get that film, we want to refer to ortho, we want to definitely monitor for symptoms, and we got to take this kid out of that sport. So that's the hard part. Injury review. So we went through all those injuries, so let's review. So what's the treatment for newborn clavicle fractures? What is a toddler's fracture, and do we care to think about if it is due to abuse? What history supports accidental trauma? What are some potential complications of fractures through the growth plates? You need to know the Salter-Harris stuff. Through mechanical forces that may cause a brachial plexus injury. What is an apophysis? Point tenderness below the knee over the proximal tibia. What is that in an adolescent who jumps a lot? Low back pain in a gymnast could be. And what does the lateral x-ray reveal? Infection and inflammation. So this is also covered in Professor Clark's lecture, but we'll just go over it. So osteomyelitis in children, the take home is that children are highly vascularized near the bone ends. So they are actually more susceptible to osteomyelitis because they have this rich blood supply. They can also have infarcts in those regions if they have a hemoglobinopathy. So the most common sites are going to be the femur and tibia. Osteomyelitis presentation, right? So infection in the bone. It's going to be pain, reduced function, heat, fever. This is a sick kid, right? If it's acute, it's going to be less than 2 weeks, chronic greater than 3 weeks. We need to think of this at any age. So from 0 to 100, osteomyelitis. So what are we going to see? Well, we're going to see some inflammation, right? So you're going to have an increased SED rate, particularly if it's chronic. And you're going to have an increased CRP. So both of those will be increased. Both of those mean inflammation, right? A SED rate is more long-standing inflammation, like as in our autoimmune conditions, whereas a CRP is more acute inflammation. However, in some condition like this, they could both be elevated, and it doesn't make or break your diagnoses. They're just supporting information. CBC will usually show leukocytosis, so greater than 12,000 white blood cells per microliter, but the CBC does not rule out that there is an infectious process here. Blood culture, check that out. Osteomyelitis imaging, so basically just plain films, and we're going to see this reactive periosteal tissue. We need to rule out that there's a fracture over that portion or that there's a sarcoma. But we do definitely have this sick child, so we're going to start treating them. And here's what's happening. So you get this invasion of bacteria, and they start to inhabit this area, and they're causing this infection here. Okay, and you can kind of see it there. So it does definitely mimic a sarcoma, and so we need to make sure that we think about that. So if we're sure now that we're dealing with osteomyelitis, we're going to get some blood cultures. We're going to start IV antibiotics. Common problematic bacteria are Staph aureus, Streptococcus, Klebsiella kingae in young kids that are in childcare setting. Slow onset of this disease, so that's kind of something to keep in the back of our mind. Also, people with sickle cell disease, for whatever reason, are really more prone to salmonella. At one time, I knew why that was, and now I don't recall. However, I would really think that would be great if you looked that up. Puncture wounds through a sneaker, they're more likely to have Pseudomonas secondary to that deep puncture wound. Haemophilus influenza if they're not vaccinated. So antibiotics in inpatient for 4 to 6 weeks, and they may need surgical debridement. Arthritis in a child. So the definition of arthritis is inflammation of a joint, either chronic or acute, which tissue of the joint and which etiology. So each joint has unique characteristics, and we need to know that so that that will help you decide where this inflammation may come. Weight-bearing persons and young people are more likely to manifest in the joints that are affected or are being challenged. 7 types of juvenile idiopathic arthritis are all right here. These will be covered also in the other sections. Case of a hip strain. So sprain, you've got a 4-year-old with fever, leg pain, and slip after slipping and twisting her right leg the previous day. She's diagnosed with a hip sprain and sent home with ibuprofen, but she returned for worsening pain and the inability to walk. So she is in a adducted position with her knee in approximately 75 degrees of flexion. She's definitely trying not to probably move this hip, and she's sick. So it's probably septic arthritis until proven otherwise. So we got to do, what do we want to do for this patient? We want to image, we want to do labs, and we want to treat aggressively. So usually septic arthritis is in a single joint. It's consistent with fever, swelling, and erythema. There's going to be most likely a bacterial source via the bloodstream. There's going to be a surrounding cellulitis and potentially a puncture wound. So basically you have this event and you predispose the body to absorbing bacterium past its skin barrier, and that then makes its way into an adjacent joint. So we need to aspirate that fluid ASAP. We got to do a gram stain culture, cell count, glucose, lactate dehydrogenase, right? All that. CRP, CBC, CMP, of course, to look for renal function, and then some blood cultures. IV antibiotics, and then we can go to PO antibiotics, and we want to follow their CRP. C-reactive protein is a good indicator of treatment progress, so we can watch that along. We're going to cover for staph and strep. We want to remember that Klebsiella kingae can be a bad actor. We want to think about Haemophilus influenza B if they're not immunized, and if they are sexually active, we want to consider Neisseria gonorrhea. May repeat the drainage to see how we're doing as far as susceptibility testing and to make sure that our bug is being treated correctly. So the hip strain continues. So now we aspirate the hip. We get 800 or 80,000 white blood cells per microliter, and they're 88% segs. So that's highly sensitive and specific for a bacterial infection. You've also got a left shift, and you're going to see some streptococcus. So you're going to need a cover with Bactrim and Keflex. Septic arthritis, prompt diagnosis and treatment. So let's take a look here. I'm looking. This is the hip, and you can see how these are fairly well defined. And here you've got all this inflammatory change. Reactive arthritis, so a transient toxic synovitis of the hip. They're going to be afebrile with a limp after a URI. So they have this history of preceding viral infection, and then they end up with this irritated toxic syndrome. Labs are going to show, kind of all over the map. We will want to exclude osteoarthritis and septic arthritis. So if we need to do that, we may need to aspirate and then send out some viral cultures as well. Juvenile idiopathic arthritis, so greater than one joint and greater than 6 weeks, has to exclude infection, malignancy, trauma, or reactive arthritis, connective tissue disease like systemic lupus erythematosus. So we need to do a big lab workup on this child and make sure that we excluded that. But it's this autoimmune condition that targets the synovium, causes joint pain and stiffness, and is also associated with this anterior uveitis. So 15% of them are oligoarticular, means less than 5 joints, and 40% are polyarticular, so greater than 5 joints. Main types of juvenile arthritis, 10% are systemic. They may have other areas other than just the joints that are affected. They're going to have this fever and a rash. There is no diagnostic tests. We just have a good history that fits. We may have a positive ANA. That's going to put them at increased risks of uveitis. And their RF is more likely positive in adolescents. If we aspirate, we're going to see lymphocytes. And also in the blood, we might see a chronic anemia due to the fact that they have chronic disease. So this juvenile idiopathic arthritis, they're going to talk about the uveitis, they're going to talk about the joint pain, they're going to talk about the fever, and then they've ruled other things out. The prognosis is that there's an 85% remission rate. It can potentially have lifelong complications. There's that uveitis. So the inflammation of that ciliary body causes abnormal pupillar constriction. Systemic lupus erythematosus, so may have an onset in childhood with arthritis and arthralgia. The hallmark of this is that malar butterfly rash. Benign or pathologic. So we want to look at some lesions here. These are some radiographs that were obtained secondary to pain. And you may have incidentally found a bone cancer. Well, yes, you have 3 of them. So you've got 3 different cancers here, which you guys have pretty much gone over or will go over in Holly's lecture. However, we'll just kind of go over them. So some non-malignant lesions are an osteochondroma, a benign bone cyst, osteoma, and Brody's abscess. Malignant is osteosarcomas, Ewing sarcoma, and leukemic infiltrates. So an osteosarcoma occurs in adolescence. You'll see it at the metaphysis. It can affect the tibia, humerus, and femur. And there is this bone pain and swelling around the pathologic site. So, this is when you want to really investigate that nighttime pain. So you can see all that reactive calcification around that. Ewing sarcoma, usually in the long bones and pelvis. They're going to have that bone pain, and there's going to be this swelling and pathologic fractures. Bone sarcomas, both are treated with chemotherapy and surgery. Ewing's is also radiosensitive. Prognosis best if localized, 60 to 70% survival rate. Survival is poor with metastasis, 90% mets to the lungs. Ewing sarcoma and osteosarcoma are both displayed there. Benign sarcomas, so these are some benign sarcomas. So 7-year-old with ankle swelling, no pain. 2 other children also do too. So these are those ones we first saw and we said, oh, they're cancer. I did. But this is an osteochondroma. I would have no idea. Unicameral bone cyst, and then an osteoid osteoma. So what we basically do is rely on our radiologists here, because if I saw any of these, I would pretty much be freaking out. Musculoskeletal pain, so difficult for children to localize. So we want to think about a lot of causes here. There's a high prevalence that pain will increase with age, and they'll be better able to isolate where the pain. We want to think about pathologic causes if it's a young kid, if it's limiting their mobility, or if it's awakening them from sleep. Musculoskeletal pain evaluation, so when did it start? What's the location? What makes it worse? Some differences we need to understand between benign musculoskeletal pain and serious, and these are some red flags. So is there pain at rest? Usually with a benign pathology, the pain decreases during rest. Is it okay and treatable with a simple analgesic like Tylenol? Then that would be more consistent with a benign process. If there's joint swelling, that would be more concerning. If the joint is stiff, that's more concerning. And if there's actual bony tenderness, that's also more concerning. So benign nocturnal limb pains are these growing pains. This is a diagnosis of exclusion. They generally resolve by the morning and don't wake them from sleep. Usually they might complain about it while they're trying to sleep, but they won't wake up due to it. So if in doubt, we want to do CBC, CRP, Sedrate, and a plain film. Hypermobility is a common finding in young children. As they age, though, we want to be concerned about some of these connective tissue disorders like Ehlers-Danlos, Marfan syndrome. These individuals are more prone to a whole bunch of things, but aneurysm is probably one. Also, spontaneous pneumothorax. Chest pain in kids, so you'll see this a lot. Everybody's worried about chest pain, and we worry about our kids, so we want to make sure nothing's wrong with them. So, if you can't reproduce it and it's there's no good cause to it, then you may just do a chest x-ray and EKG to make sure that there's nothing concerning going on. In the ER, everybody gets a chest x-ray EKG. It's just good medicine. So to review, what are the most common sources of bone and joint infections? Most common bacteria causing childhood osteomyelitis and septic arthritis. An afebrile 4-year-old with a limp after UIRI and normal diagnostics. Polyarticular juvenile idiopathic arthritis. How many and which size joints would be involved? Blood test that confirms juvenile idiopathic arthritis. What if it's associated with uveitis? Peak age for bone cancer. What are some HPI red flags for pathologic musculoskeletal pain? And last but not least, active 7-year-old with bilateral leg aching only at bedtime. That is a rapid musculoskeletal review. So I hope you guys find that helpful. And you need to pair that with Professor Holly Clark's lecture on She's going to talk about infections and neoplasms. So she'll piggyback on some of that stuff and elaborate on some of that stuff. And also Sean has 3 room lectures, which he'll definitely elaborate on a lot of that. So that may just be the room stuff, and the cancer stuff may just be extra and more of a pediatric focus. However, they will also review that. So hope you guys are doing well, and I will post a review for the test, as well as a short video to kind of walk you through what you need to know, and what you really need to review on that focus review, which will be like a study guide that I'll put out soon, probably tomorrow. All right, take care.